it from the gut to the butt. I'm Beverly Tomasian. My pronouns are she, her, and hers. And I'd like to welcome everyone here today to this very special program. Before I kick off, I'd like to do a land acknowledgement. We acknowledge and are mindful that Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda. We recognize their distinctive spiritual relationship with this land, the flora, the fauna, and the waters that run through this area. This is such an exciting month because we have Diabetes Month is all of November. And then on November 14th, we celebrate Dr. Frederick Banting, who is one of the individuals that's attributed with the discovery of insulin. He led the research study out of Toronto, Canada, and said, I think we can isolate this hormone they called insulin and replace it so folks who don't have a functional pancreas can benefit from this hormone called insulin. And certainly we can see this little boy in December 1922, his pancreas is not working at all. He has type 1 diabetes. And without that hormone, insulin, you cannot thrive. You cannot store energy. You can't store fat or glucose as glycogen. And you certainly can't store amino acids and make it into muscle. But 2 months after receiving insulin therapy, here is that same little boy. He doesn't look a lot happier, but he is definitely thriving. He's got fat in his cheeks. He's gaining weight. It's such an amazing miracle that we have access to insulin via injection, via pumps, inhaled insulin. So now that no one need go without insulin. Of course, if we think about social drivers of health, we've heard lately in the news that many individuals may not be able to afford insulin and might have to ration it out. But hopefully with new legislation coming and new regulations as far as pricing of insulin, we'll see insulin continue to be accessible for all. We are going to celebrate World Diabetes Day, November 14th. That's because it's the birthday of Dr. Frederick Banting. So we'll be celebrating his birthday November 14th, and that's the reason they celebrate World Diabetes Day on November 14th is to honor and recognize his his hard work and dedication to making insulin available to all. And certainly he had a team of researchers that supported him, but he was the inspiration for it. We are here to help. I have an amazing team. This is Brianna, our Director of Operations in Australia, our newest team member who is here to support with your questions, customer service, problem solving. I mean, our whole company is geared to supporting you in getting the best diabetes education and also moving towards certification and renewing your certification. And of course, we are an inclusive-based company. We are committed to promoting diversity and inclusion in our educational offerings. And throughout courses, we recognize and discuss social drivers of health and look at not only pathophysiology of diabetes, and of course, we always use the most evidence-based information, but how does this person living with diabetes, who's at the center of the conversation, manage it on a day-to-day basis? So we just keep trying to bring that humanity and compassion to the forefront and looking at people from different lived experiences. As far as conflict of interest, I have none to declare. Now, where did I get the information for this talk? And this talk is one of my most popular talks because we get to explore a lot of different areas that we normally don't talk about that much. But there's several books. Gulp by Mary Roach. I just saw it. I was walking in the airport the other day and it was for sale. This book by Gulia Enders she was a medical student and she got really fascinated with the intestinal system. Who wouldn't? The alimentary canal, and decided to write a book about it. And really beautifully discussed an exploration of this 30 feet of intestine that we often take for granted. And then we have Rob Knight. Rob Knight really got me excited about the microbiome of the intestine. I was listening to a TED talk by him, and this was over 10 years ago. And I'm like, what? The bacteria are influencing our health, the bacteria that live in our intestine. And there's 3 pounds of bacteria in our intestine. Does that mean when I weigh myself, I can subtract 3 pounds for these hitchhikers that are dwelling, in my abdomen? Anyways, so this very inspirational book, it's a short book, but full of content related to the importance of the microbiome. And of course, there's more advanced levels books on this content now as we have more research, but certainly a field that is expanding, and the ADA is even talking in their standards of care. They had one sentence that the gut microbiome can influence overall health of the individual. So I'm holding on to that one sentence, hoping that in the future we have more conversations around that and it enters evidence-based care and is part of what we consider when we work with people with diabetes. But what are we going to talk about today? We'll look at the complications of the GI system from the mouth to the intestines. So we're going to do a whole exploration of the alimentary canal. We'll start with periodontal disease, gastroparesis, steatosis, endocrine and exocrine disorders of the pancreas, infections. We'll look at the relationship between our gut health, microbiome, diabetes, inflammation, and we'll also look at strategies to improve gut microbiota. But really what I want to do is enjoy a state of wonder. Like, putting this program together is so fun for me because I get to explore different areas I normally wouldn't tap into and kind of be amazed at the functionality of the body and all the different factors that influence our health. Let's start with the gut tube embryonic starting point, which is a great place to start. When we're when we're developing as embryos, we have three main tubes that our organs develop out of: the mesoderm, the ectoderm, and the embryonic endoderm. So I'm going to start with the endoderm, that tube that actually develops into the respiratory system and our digestive tube. And the reason I do this is because you can see how all these digestive functions are interrelated. And when people get diabetes, many of the functionalities of this digestive tube is affected. And you can see our oral membrane. We'll talk about that. The thyroid, as we know, diabetes and thyroid disease go together. Lung development, even though I'm not going to talk about the respiratory system, we do know that diabetes can affect the health of the lungs. There's a relationship between the gut and the lungs also that we know. So, our body is definitely interconnected, as you all know that, but it just really brings it to mind when we look at how we started, how this tube had to differentiate into these different organs. And it makes sense that diseases that affect one part of this embryonic tube might affect other parts of us as adults. Okay, we have the midgut, we have this midgut, and we have the hindgut, and we have all these different aspects: the esophagus, the stomach, small and large intestine, the liver comes from this embryonic tube, the gallbladder, the pancreas, and the thyroid gland and parathyroid, but they lose connection before birth to become endocrine organs. The parathyroids do. But just kind of thinking about these different organs, we definitely know diabetes has an impact on many of these. So let's talk a little bit about digestion. And when we think about eating, when you look at this picture or when you look at food, our enzymes are being released from our mouth, our amylase and other digestive enzymes. Our pancreas might start squirting out some insulin and some gut hormones. So our body is preparing for this food bolus that's going to be coming down the pike. And it's going to be thinking, well, what should I release to help with digestion of these components? And I want to ask you a quick question before we talk about digestion. JR thinks that their ability to taste foods has diminished recently. They ask you, what are the confirmed 5 basic tastes of the tongue? Which of the following describes the best answers? So if you wouldn't mind just typing in, and this really, what you think are the 5 flavors that the tongue can feel. Well, the tongue can assess, I guess, or register to send up to the brain for interpretation. This really came to light with COVID, where we lost our sense of smell and taste, and how important the ability to sense different flavors is for human beings for safety. When we had more primitive living situations, we had to understand which foods were toxic and which were not, and their sense of taste was very important in keeping us safe throughout our evolution. Okay, so the 5 flavors, here we go. We have sweet, and you could see different parts of your tongue assess this. We have our sweet, we have our sour on the sides, we have our bitter in the back, and umami. Now, umami just recently came into, I guess, fashion, is it the way I'd say it? A researcher in Japan had detected over 50 years ago, and he kept saying there's umami, but it took the scientific community a while to recognize and actually add umami to the tongue's ability to sense this flavor. So that is considered savory. And the tongue might also detect ammonium chloride. And there's a USC recent discovery, and they're thinking, maybe we can detect ammonium chloride to avoid toxic substances. So I know there's going to be more flavors that we can detect in the future, with science catching up to it. And this black licorice, I think from New Zealand, some people can taste the ammonium chloride in it. And that was kind of the start of the research into, oh, do we taste ammonium chloride as humans also? Is that another flavor that we can detect on our tongues? So more to come on that. So as I said earlier, we just look at food and our eyes make an appraisal of our eyes are sending information to the brain to make an appraisal for the incoming load. How much carb, how much protein, how much fat, how much insulin do I need, how much gut hormones. And then our glands secrete saliva, and our salivary enzymes contain amylase. And then we chew the food and we create a bolus with that saliva and the digestive enzymes getting to work. And then our upper pharynx and esophagus is under conscious control. But once we swallow, it's out of our control. It's all voluntary. Our esophagus smooth muscle is controlled by the brain. And also, of course, we don't control our sphincters that allow food to go into our stomach. That's also controlled by the brain. And that little gateway, that sphincter from the esophagus to the stomach, is an important gateway to prevent reflux of gastric content. So if we take a look, thank you for typing in the different flavors. So if we just take a look at what we're going to be talking about, the alimentary canal, you can see we start with the food and it works its way down through the esophagus. And then we have a bunch of organs right around the stomach. Now they're perfectly positioned there because they're going to give the stomach different enzymes and different tools to help break down the food. So we have the pancreas here, the liver, the gallbladder, and then here's the stomach, and then here's the intestinal tubes that are so important in helping us absorb nutrients. So the stomach is relatively high up, and I think a lot of times we think it's lower, but it's just touching upon the lower lobe of the lung right here, which can explain when we eat how we feel that pressure up a little bit high until it reaches down and hits the duodenum and makes its way through the canal. So let me just start with our first poll question. Diabetes is associated with an increased risk of oral disease. Which of the following statements is true? A, people with diabetes benefit from vinegar gargles to decrease bacterial load. B, people with diabetes are at greater risk for tongue cancer. C, 1 in 5 cases of tooth loss is linked to diabetes. Or D, diabetes is associated with increased tonsillitis. Okay, so I'm going to launch the poll question. I'm going to talk for the first one to let you all know that it doesn't matter if you choose the best answer or a different answer. It's just this opportunity to flex your analytical skills and to get some feedback. So whether if you choose the wrong answer, it's a learning opportunity. And if you choose the right answer, it's also a learning opportunity. So this is a safe space is what I want to say. So please make a choice. I'm really going to stop talking now. Okay, we'll wait about 10 more seconds. Thank you for your participation. Okay, I'm going to close the poll and share your results. So 81% of you chose C, 10% chose B, and another 10% chose D. What is the best answer? Well, the best answer actually is C. We know that people who have tooth loss are more likely to be experiencing diabetes, and people with diabetes are more likely to experience tooth loss. That's why we really love having partnership with the dental community, because dentists can often evaluate people who have undiagnosed diabetes or diabetes that needs a little tune-up. Because if blood glucose levels are elevated, it can certainly increase the risk for periodontal disease and tooth loss. So people with diabetes are not at any greater risk for tongue cancer, and they're not at greater risk for tonsillitis, but tooth loss is a big deal. Now, here's the thing. When people have diabetes and their blood glucose levels are elevated, they make less saliva. So you all know when you're dehydrated, your whole body makes less fluid. It's going to try and conserve the fluid, so people's mouth become drier. And you'll notice when people with new diabetes or people with elevated blood glucose levels, I'll say to them, oh, how many times a night are you going to the bathroom, or is your mouth dry? And if they say yes, then we really want to encourage them to increase their intake of water, of course, along with lowering their blood glucose is most important. But when we don't make enough saliva, it's harder to chew our food. There's not as much digestive enzymes, of course, and also it's hard to swallow the food. And when we don't make enough saliva, we're not cleansing our mouth and our teeth with that saliva that's really trying to decrease the bacterial load in our mouth. Super important to get blood glucose down to make sure people have adequate salivary production, and also that there's not a lot of sugar in the saliva. People with extra glucose in their blood, that glucose spills out into their secretions, including the saliva. And that means that now the teeth are being bathed in sugar. So really important. I talk about mouth care a lot when I meet with people with diabetes, and I work at a Indian Health Services clinic once a week, so I'm always talking about, have you seen a dentist? Do you brush your teeth? Do you floss? It's such an important part of care. So I think I've said all of this. And dry mouth can lead to increased risk of infection and can really affect nutritional intake. When people have a dry mouth, it's hard to chew. And we also know if they have tooth loss and they don't have dentures or other, replacement teeth, that it can make it really difficult to chew too. So periodontal disease is more prevalent with diabetes and elevated A1C. We know when we treat periodontitis with antibiotics or tooth cleaning or regular dental care, it can actually impact A1C. So we definitely know that the health of the mouth affects the health of the body, and it can also affect the A1C level. And we know that people with periodontal disease have higher rates of diabetes. People with diabetes have higher rates of periodontal disease. So we want to encourage daily flossing, brushing twice a day, seeing dental hygienists for tooth cleaning, and of course, the dentist. We also know that when there's a lot of bacteria in the mouth, the mouth has a lot of capillaries innervating it, so that is lead in that blood circulates from the mouth. The bacteria from the mouth enter the bloodstream and enter circulation, and they can actually lead to plaque formation in the heart and increase the risk of heart disease. So we know that people who brush and floss live longer. So the best $10 you will ever spend. And in our clinic, when we have a person who comes in new to see us with diabetes, we give them a toothbrush, toothpaste, and dental floss. And it's an important investment in their oral health and their overall health and well-being. Okay, so we've made it to the mouth, and we went down the esophagus. Let's head to the stomach and beyond. So we can see here we have the sphincter that lets the food into the stomach, and this upper part is kind of the cardiac region or the fundus of the stomach, and that's where food enters originally and kind of sits there waiting to be propelled down into the body of the stomach for digestion and breaking down of the nutrients. So this is kind of the docking station, and the stomach is going to gradually move the food down until it flows through to the duodenum. Okay, and then we have the gallbladder releasing its bile to help break down fat and other nutrients. And we have from the pancreas digestive enzymes that are going to be entering once the food hits the duodenum. Okay, And we'll talk about the pyloric sphincter in a little while, but we definitely know that people with diabetes can struggle with gastroparesis, and gastroparesis is, of course, paralysis of the stomach. So that muscular movement of the stomach doesn't happen as effectively, and it's really hard for the content of the stomach to go past the sphincter and get into the duodenum, and that can cause a lot of distress for people. But before we get to that, let's talk about this poll question 2. Best definition for borborygmi. Does borborygmi mean a tropical fruit used for nausea, stomach rumbling, gastric reflux, or treatment for constipation? What is the best definition for borborygmi? And this is kind of just a fun one. So take your best guess, please. Tropical fruit used for nausea, stomach rumbling, gastric reflux, or treatment for constipation. All right, we'll wait about 10 more seconds. Okay. Thank you for not looking at the answer on your phone, because that would be super tempting. All right, I'm going to close the poll and share your results. 71% of you participated. 24% of you said it sounds like a tropical fruit. 12% said, well, that's gastric reflux. But most of you chose the best answer. It is stomach rumbling. So what is that stomach rumbling sound? And I mean, for some reason in our culture, there's some embarrassment around it. I'm not sure why. It's what the stomach is doing. It's contracting to help move the stomach contents forward. So the stomach is a very active muscle, and it needs to propel the food down toward the duodenum. So what happens in the stomach? Well, as I mentioned, the food sits in the fundus where it's held and mixed together. And then the gastric juice from the stomach starts breaking down the larger particles. And as their particles are broken down, the food moves to the lower regions and is broken down even into smaller particles by acid and motility. And the gurgling and stomach rumbling is an audible reflection of movement. Now, this is kind of interesting to me. I did not realize this, but the stomach is very specific on how quickly it moves the calories to the duodenum. And usual meal takes about 4 hours to pass through, or about 1 to 4 kilocalories per minute. So interesting. Of course, that's going to be affected by the content of the meal. If there's a lot of fat and protein, it's going to take longer. If it's mostly just carbohydrates, it might move a little more quickly. And of course, fiber is going to play a role in there. But the stomach is very particular on how quickly it moves that content forward, because of course it's trying to maintain glucose stability and prevent these glucose fluctuations as much as possible. So you can see here, protein fatty meals can take up to 6 hours. Now, digestion time is based on calories. So if I eat 400 calories, if I move my stomach contents through at 4 calories a minute, it's going to take 100 minutes or 1 hour and 40 minutes to digest. But if I consume 1,000 calories, it could take me up to 4 hours and 10 minutes to digest. And then if I'm eating, like I mentioned earlier, maybe this is a steak meal with a lot of butter and potato and sour cream. And so it might even take up to 6 hours. And this is really important to consider when we work with people with diabetes, because we can see that insulin timing and dose of insulin and how we deliver insulin is going to really have a big impact on what post-meal blood glucose levels do. That's why it's so great with the pumps, where we can do dual waves, or for some folks, they might give a little bit of insulin before the meal starts. And if they know they're going to eat a high protein, high fat meal, they might cut the dose in half and give a little bit before the meal and a little bit after the meal to kind of account for that delayed digestion. But this is why diabetes is so hard to manage, because there's so many things that are happening in the body simultaneously that the person living with diabetes has very little control over. This is all autonomically based. Movement of the stomach content. And it also depends, on the weather. Does that person have gastroparesis? Do they have, other factors that might be contributing to the outflow contents from the stomach. So I want to talk a little bit about stomach issues that we might encounter. And I'm going to talk about three of things: the H. pylori infection, gastroparesis, and metabolic surgery. So let's hang out in the stomach for a little bit longer. But I just want to introduce Bruce Springsteen. And this is a picture that's about 2 years old. But 2 years ago, Bruce Springsteen was going to go out on tour. And if you don't know who he is, he's a singer and a performer. But anyways, he couldn't go out on tour because he had peptic ulcer disease. So it was causing a lot of stomach pain and other factors. Now, I don't know the origin of his peptic ulcer disease, but I was thinking maybe he had an H. pylori infection. Now, H. pylori, and some people say H. pylori, so it's H. pylori is the correct way to pronounce it, so I just want to say that out loud. But I've been saying H. pylori for so long, I'll probably continue saying that. But 50% of the world's population coexists with H. pylori. And so most of us were born with H. pylori, or our parents, gave it to us. And it's just part of those bacteria that hang out in our stomach. And most of the time, it's fine. It's just part of our digestive bacteria that are hanging out, helping us absorb nutrients and fight off invaders. But in a small percentage of people, this H. pylori goes rogue. So it was doing fine, but all of a sudden it decides to start causing harm, and it actually drills through the mucus lining of your stomach, and it just starts eating it. And this mucus lining is an important protective barrier to prevent acid from hitting your stomach lining, causing damage to your stomach. So this H. pylori can cause stomach pain, burning, feeling of fullness or bloating, hunger and empty feeling in the stomach, often 1 to 3 hours after a meal, nausea that might go away with vomiting, loss of appetite, weight loss without trying, burping, bloody or dark tarry stools if that ulceration in the stomach is causing bleeding. So about 10 to 15% of people infected with H. pylori develop peptic ulcer disease, and this increases the risk for stomach cancer. Now, the good news is we have treatment for H. pylori, and it's a course of antibiotics that will kill this rogue H. pylori bacteria. But people with diabetes are at increased risk for H. pylori, and people with H. pylori are at increased risk for diabetes. Again, another bi-directional situation. So I just want to spend a few more seconds on this. So we want to, one thing that people will complain about with H. pylori infection, especially, is when their stomach is empty, it burns. It's really hurting. So if a person's saying that to me, I'm like, have they ever tested for H. pylori? So that is a big sign that we want to consider. And it's a very simple test to see if a person is positive for H. pylori. And like I said, it's a series of 2 antibiotics taken for a few weeks that will help get rid of it. And man, people feel a lot better. And we also want to treat it to help prevent potential risk for ulceration and cancer. Okay, let's take a look at JR. JR has lived with type 1 diabetes for over 30 years and has been complaining that they feel full and bloated after eating and experiencing more post-meal hypoglycemia. Based on this information, what is the most appropriate recommendation for JR? A, evaluate transglutaminase levels. B, encourage small, frequent, low-fiber meals. C, suggest a consult for a gastric pacemaker. Or D, recommend they try avoiding foods with gluten for a few weeks to see if they feel better. Okay, we have this person with type 1 for 30 years complaining that they feel full and bloated, and they're having more post-meal hypoglycemia. And I'm going to launch the poll. Based on this information, what is the most appropriate recommendation for JR? Evaluate transglutaminase, encourage small, frequent, low-fiber meals. Recommend a consult for a gastric pacemaker. Or encourage them to avoid gluten. All right, I'm going to go ahead and close the poll because 93% of you chose the best answer, which is encourage small, frequent meals that are low in fiber. And that's hard for us to say, right? Because with diabetes, we're all about fiber. But what I'm thinking is this person has gastroparesis because they feel full and bloated after eating. They eat and that food just sits in their stomachs. It's not passing through to the duodenum. And also this post-meal hypoglycemia is a really important clue because they're giving insulin before the meal, assuming that that meal will be absorbed within 2 to 4 hours. But then we see that they go low after eating, which means the food is not able to move from the stomach to the duodenum. So their blood glucose levels are crashing because they can't absorb those nutrients. And that's a very common sign of gastroparesis, post-meal hypoglycemia. If people are complaining of that, along with saying, man, after I eat, I just feel like there's a brick in my stomach, it may mean that that stomach content is not moving forward. And we know that gastroparesis is an autonomic neuropathy. That is, if I've had elevated blood sugars for a period of time, my autonomic nervous system starts becoming impacted. And the autonomic nervous system is involved in moving the gastric contents forward in the stomach. So there's nerve innervation that tells the stomach move the stuff forward. And with autonomic neuropathy, that message may not be getting through. So it can happen at varying degrees, and we know it gets worse when people's A1C levels are elevated, but people with type 1 diabetes, long-standing diabetes, and it can result in what I've talked about. In addition to post-meal hypoglycemia, they might feel like vomiting after they eat. The stomach content feels like it's backing up. And how do we diagnose this? Well, we'll do gastric emptying studies. We'll look for postprandial hypo. And again, the improvement here is getting blood glucose to target. But even sometimes with really great glucose management, the gastroparesis can persevere. And we want to make sure that everyone with gastroparesis needs to see a dietitian, a GI specialist. And we're going to do small, frequent meals. With a lot of the folks that I've worked with, we'll do liquid calories first, if that's having something like a milkshake or a protein drink, or blending their food to make sure they get nutrition that can go through, followed by a food that is, that they are chewing and that might take a little bit longer to digest. And so this person is going to need a lot of very personalized attention to figuring out how do they give their insulin. Do they give a little bit before the meal? Do they wait till after the meal to give the full dose, or do they need maybe insulin pump therapy to help account for this? So nutrition for gastroparesis, dietary changes in addition to getting blood glucose to target are high priority. And we also want to make sure they're getting adequate calories. So looking for fat intake. Fat is a good high source of calories. So we try not to limit fat intake until we've exhausted everything else. And liquid fats may be tolerated better than, like eating a high fat steak. So our goal here is to maintain adequate nutrition and make sure they're getting adequate calories through to prevent sarcopenia and wasting of muscle and maintaining their healthy weight. So again, we want to also consider, do they need some multivitamins and supplements if their intake is insufficient, and making sure they chew foods well and sit up for 1 to 2 hours afterward. Let's get gravity involved in helping move their stomach content forward. And some people have even said walking after a meal can be really helpful too. Now, I had a person reach out to me. This is a person I've been working with for a long time, living with type 1 diabetes and gastroparesis. And they were ending up in the emergency room frequently because of this gastroparesis. And they told me, well, my doctor said maybe I need a myotomy or a GPOEM procedure. So this GPOEM stands for gastric peroral endoscopic myotomy. And I'm not endorsing this by any means. I'm just bringing it up as a treatment strategy. We know we have gastric pacers. Some parts of the country will actually put a pacer on the stomach to increase motility. And of course, the nutrition interventions I've mentioned are another treatment, getting blood glucose to target. But for this person I've been working with, nothing was working, and they were really losing a lot of weight. So let's just take a look at what this procedure entails. As we know, the gateway from the small intestine to the duodenum is the pyloric, or the pyloric sphincter. The food knocks on the door of the pyloric sphincter for admission to the duodenum, and usually that sphincter really opens up easily and the food can get right through to the duodenum. But for some reason, with people with gastroparesis, that pyloric sphincter can become stiff, closed shut. It doesn't open even when there's food in the duodenum. I mean, there's food in the stomach asking to pass through to the duodenum. And this was the case with my client. So what they did, this endoscopic procedure where they cut the muscles near the pyloric sphincter, a myotomy, and it helps to permanently relax the sphincter so food can empty freely. And I'll just give you, this is an N of 1, but the person that received this myotomy has felt so much better, and now the food is able to go into their duodenum, and they don't have as many admissions to the emergency room with gastroparesis. Those have really almost been eliminated. So I want to say we want to give people hope and options, and they could certainly look into this. I mean, this is a video from Johns Hopkins University where they're doing the procedure. There's a lot of great information out on the internet about different options for people with gastroparesis, including the POEM as one option. And then I think a lot about gut hormones. Now, our gut hormones are very involved in glucose regulation. And we have gut hormones secreted by the L cells of the intestine. Those are our GLP-1s. And our GIPs are released by the K cells of our intestine. So some of the gut hormones are released in the small intestine, but most of them, the gut hormones are released from the larger intestine. So actually, this is an interesting point. We think of our gut now as an endocrine organ. I mean, it hasn't been officially deemed an endocrine organ, but a lot of gastroenterologists are calling themselves endocrine gastroenterologists, because there's so many hormones that are released from the intestines that it's influencing glucose regulation and other factors, of course, in our body, that we are looking at the intestine from a much more nuanced perspective. That people with type 2 diabetes make about 50% less gut hormones. And there's a new study that showed people with type 1 diabetes may benefit from GLP-1 therapy in early diagnosis. And so we know that people living with type 1 diabetes are talking to the FDA and asking the FDA, please approve the GLP-1s for us too, because lots of folks living with type 1, of course, they need insulin, but sometimes they're struggling with extra weight and they can't get their blood glucose down. And, some studies have suggested that people living with type 1 really do benefit from the addition of a GLP-1. It's completely off-label as we speak, but the groups of people living with diabetes are really petitioning the FDA to consider approval. The thing with GLP-1s, especially if I have gastroparesis or other intestinal issues, is that it does slow down peristalsis. So it can slow down gastric emptying and movement and transit time through my intestine, which may be a problem if I have Crohn's or irritable bowel syndrome or, other intestinal issues, especially, of course, gastroparesis. And for folks with disordered eating, it might not be a good match. We have to evaluate everyone individually, but we do know that there is a warning now for semaglutide for intestinal blockage, and we think it's a class effect that other gut hormones can also cause a slowing of intestinal peristalsis and in rare occasions lead to an obstruction. So these GLP and GIP-1 hormones are very influential on satiety and glucose regulation. So you can see with the GLPs, they are going to affect the central nervous system, They're going to increase satiety, decrease food intake. They can cause some nausea, decrease in body weight. They stimulate the pancreas to make more insulin and tell the pancreas, don't make so much glucagon. They slow gastric emptying and contribute to lowering of the blood glucose. And the GIP-1s have similar actions. They decrease food intake. And actually, when we combine the GLP and GIP, like the tirzepatide, people seem to have a little bit less nausea with the combined hormones, and definitely an increase in body weight than just using one hormone on its own. It tells the pancreas to make more insulin. Interestingly enough, this can contribute to increasing glucagon secretion too. But both of these hormones are going to have the end net result of lowering post-meal blood glucose in particular, because they're stimulating the organs involved in digestion and glucose regulation to do their job. And when we have diabetes, when we make less of these hormones, so by replacing them through either generally start these medications at a very low dose, the lowest dose possible. And we used to say increase, once monthly till we reach target. And my new pocket card actually says increase based on collaboration with the person and what feels right to them. We're much more we have learned that by increasing the dose very quickly, people are more likely to abandon this medication. And by 1 year of taking this medication, up to 40% of people will have stopped taking it because of the side effects. So we've learned that by gradually increasing and doing it based on the person's goals, it's more likely to be tolerated. And then what about when a person reaches their weight target and their glucose target? What do we do then? And this is just totally off label. This is Beverly just sharing what I've been reading in on different journal articles, that they're actually seeing for some folks on maintenance GLP-1s, maybe taking the injection every 2 weeks instead of every week, and seeing if they can maintain their weight and their A1C and their blood glucose on a lower or less frequent injection. So we're learning so much about this class of medications right now. And we want people to be able to tolerate it for the long term, because the benefits are not only in lowering blood glucose and body weight, but you can see here they significantly reduce the risk of cardiovascular death, heart attack, and stroke. Semaglutide has also been recognized for its kidney protection, and this class of medication seems to actually help people with heart failure. So, man, a lot of benefits we're discovering with these ongoing studies. But you can see they drop A1C 0.5 to 1.6 with a single hormone, and with a dual to incretin, we have even a greater body weight loss and A1C drop. Now, the oral Rybelsus, I just want to say that there was original dosing of 3, 7, and 14 milligrams. People were experiencing a lot of nausea with that. So they actually have a new dosing level where you can start at a lower dose to help people tolerate it. And there's a lot of new medications of this class in the pipeline. So I'm excited to see what's going to be approved next, and how am I going to fit them all on my pocket card is a big question for me. Sorry, y'all. Okay, it looks like my mic was out for a little while. Okay, I'm back, so that's good to know. And the great news is the recorded version will have the audio. So even if it went out on your side, the recorded version will have the audio. Now, I went to this really interesting talk, and this physician was saying, if we continue at this pace with prescribing these GLP-1s and GIPs, it's going to cost our health system, trillions of dollars. And he brought up an interesting point that metabolic surgery is on the long run less cost intensive, it's less expensive, and it has some good outcomes that we want to consider. And so that was, I hadn't really thought of it like that. But with the GLP-1s and the GIP combo medication, we can imagine that people might opt for using these medications as opposed to going for metabolic surgery for weight loss. But regardless of whether we have the gastric bypass or the gastric sleeve, we know that people with a BMI, this is from the American Diabetes Association, of 30 or greater are, especially those who we can't achieve weight loss, if their A1Cs are above target, are candidates for that. And also, this is considered as an option. So this is a conversation we might have with individuals. But if their BMI hits 40 or greater, and we would say this might be a recommended option for people with type 2 who just can't get their A1C and weight loss targets. And a BMI, if they have a BMI of 35 to 39.9 and they're trying to lose weight and they can't do it, they would also be candidates. So that's a pretty low, cutoff. BMI of 30 or greater, they say consider it as an option, especially if that person is getting complications from their diabetes and are struggling with weight loss and glucose management. And there's a stronger recommendation for those with higher weights. Now, what's the advantage of doing metabolic surgery? Well, people do experience remission. So 30 to 63% of those with the Roux-en-Y gastric bypass have remission. And remission means the A1C is at target without medications. Now, many of these have remissions. The average median is about 8 years. I've heard like 6 to 8 years is kind of the common amount of remission people have. And that remission actually is very protective on their blood vessels. So people who experience remission have less heart attack and stroke. Their mortality rates decrease, so they have longer lives, and other health benefits. So what are disadvantages? Well, I said it's less expensive than the GLP-1s for a lifetime, but still on its own, it can be costly. But it also says in the standards, it tends to be cost effective because the benefits are many. And then we have long-term concerns, of course, and it can affect, mental health. So we need to have folks very involved in mental health counseling before, during, and after the surgical procedure, because it can really impact people's perception of self and their relationship with food. So it can, bring up some big emotional issues that need to be addressed. This is just a conversation for, how are we going to manage this for the future if we know right now a lot of insurance companies are pushing back. Like if the person has met their weight goals, they're like, why do they need the GLP-1 or their diabetes goals? Are we going to keep covering it? Is insurance going to keep covering those GLP-1 therapies, knowing how much it costs their bottom line? And so they might start making it harder for us to prescribe these medications. And so, it's just a lot is going on around that topic. Okay, metformin. So let's talk a little bit about metformin. Metformin is an oral medication. It's been around for 40 years, and it lowers A1C 1 to 2 percentage points. But does it have any other benefits besides lowering A1C? Well, it seems that it does help gut microbiota in diabetes. So, and we know it also has some impact on the brain regulation too. And more investigation is being done. But it does induce GLP-1 secretion, and it provides changes in the Bacteroides to firmicutes ratio in the intestine. So it actually, can improve that ratio so people have a healthier array of gut bacteria. And it can also increase the capacity to induce mucin expression, similar to Akkermansia muciniphila. So Akkermansia muciniphila, it takes practice to say it correctly, but that actually is a gut bacteria that increases the amount of mucus lining in our intestine. And as it turns out, mucus lining in our intestine is really important because it prevents bacteria from leaving the intestinal mucosa and entering circulation. So the thicker the lining of mucus in our our intestinal lining is, the less likely people are to get diabetes and have less inflammation. So we want to protect those mucus producing bacteria, and metformin seems to help out with that. And it improves the metabolic profile by lowering tissue inflammation in the presence of extra weight. So, we know that many people on metformin get diarrhea, and maybe this diarrhea is a function of the shifting of the gut bacteria. But I want to say, I always try and recommend metformin extended release. Metformin extended release causes a lot less GI distress. But metformin, lots of people think it causes kidney problems and they stop taking it for that reason. So always exploring with people how they're feeling about the metformin. Is it causing diarrhea? Do they stop taking it because they're worried about, any side effects? And letting them know that metformin not only benefits their blood glucose, but seems to have helps improve mucus lining. So more on Akkermansia mucin, and that this is our mucus lining in our intestine. And we definitely know that our mucus lining, protects us against bacterial infiltration in our circulation, but mucus lining is also inversely correlated with obesity and diabetes in both mice and humans. So how do we increase our mucus lining? And one great way to do that, in addition to taking metformin, but what if you don't have diabetes, is increasing our fiber intake. Fiber intake is going to help increase the presence of short-chain fatty acids. Short-chain fatty acids are very important for intestinal health. So we want to feed our Akkermansia. We want to make sure we get lots of fiber involved. And ACH is associated with enhanced intestinal barrier function and incretin secretion from the intestinal endocrine cells. Together, these actions suppress obesity, insulin resistance, and intestinal inflammation. So lots of good news. And speaking of weight, we all know that weight is a heavy issue. And I love this image where we recognize that this scale, the number on this scale, will only tell you the numerical value of your gravitational pull. It will not tell you how beautiful you are, how much your friends and family love you, or how amazing you are. So we really work hard on supporting people at all weights, health at every size, and that we recognize that people with extra weight can still be very healthy, and they are people with extra weight. If weight is not the indicator of health, it's all the other measures that we do, including daily quality of life, that we really want to consider. Okay, so let's get to the duodenum, the gallbladder, and the pancreas. So after we pass the pyloric sphincter, then we have the pancreas releasing through the duodenal papilla its exocrine enzymes. And of course, we have the gallbladder giving us some digestive enzymes too as the food enters the duodenal area. So I want to talk a little bit about diabetes type 3C. Now, diabetes type 3C is really due to the structural and functional loss of insulin due to exocrine pancreatic dysfunction. What does that mean? It means, as we know, the pancreas has digestive enzymes. So those are called the exocrine function of the pancreas. And with type 3C diabetes, this exocrine digestive enzymes actually damage the endocrine function of the pancreas. So, like, for example, pancreatitis, that what can happen is that the digestive enzymes can actually eat at the pancreas and cause loss of beta insulin producing cells. So 5 to 10% of diabetes with type 3C is misdiagnosed as type 2. Now, how would you know a person has type 3C versus type 2? Well, of course, looking at their history. If they have anything like this, pancreatitis, trauma or pancreatectomy or partial pancreatectomy, neoplasias, any cancer, cystic fibrosis, hemochromatosis, those let us know this person has exocrine dysfunction of their pancreas, and this might be affecting their ability to make insulin. They also tend to be very insulin sensitive. So they don't have the genes for type 2 diabetes, so they're not resisting insulin. They're just not making enough of it. So their insulin replacement needs are on the lower side. And they might be experiencing weight loss. So if they are experiencing weight loss despite trying to keep their blood glucose on target, or they're having fatty stools are a sign that this person is not making enough exocrine enzymes and they're losing nutrients. So they can't digest those fat. And so it goes right through to their stools. And they might complain of smelly or foul smelling stools or fatty stools. And people with that situation might need pancreatic enzyme replacement therapy, or PERT. So yeah, just kind of listening for these cues. And I'm always asking people to look in the toilet after they go to the bathroom. What color is your urine? What color is your stool? Does it smell funny? Does it look funny? We need to know this. It's an important part of the whole digestive system. So type 3C diabetes includes pancreatitis. And we know that people with diabetes are more likely to get pancreatitis. People with pancreatitis are more likely to get diabetes. So let's take a look at the duodenum here in the pancreas and the gallbladder. So here's the pancreas and here's the gallbladder, and they release their bile and their enzymes through this common bile duct. And if the gallbladder has stones in it and it blocks the common bile duct, then the pancreas, the enzymes from the pancreas can't enter the duodenum. They actually back up into the pancreas and cause destruction of the pancreas. And it's a very painful pancreatitis. And also it can lead to elevated blood glucose levels. And of course, in this situation, this needs to be addressed right away if this gallbladder is blocking the pancreas from releasing its enzymes. So this person needs immediate intervention. What are some causes of pancreatitis? Well, HIV, the antiretrovirals, can actually cause destruction of the pancreas. Excessive alcohol ingestion, gallstones, elevated triglycerides, cancer, injury, and other. And as I've mentioned, people with diabetes have 2 times the risk of acute pancreatitis. And after one episode of pancreatitis, 1/3 of people will get prediabetes or diabetes. And about 25 to 80% of people with chronic pancreatitis develop type 3C diabetes. So again, our assessment is so important because many of these folks are misdiagnosed as type 2, but they would really benefit from some digestive enzymes, making sure they're maintaining their nutrition. They might need some supplementation. So pancreatitis is an exocrine dysfunction that disrupts the global architecture or physiology of the pancreas, and it results in both exocrine and endocrine dysfunction. So, as I've mentioned before, to detect this type 3C diabetes, these are some clues that would let us know the person could benefit from some enzyme replacement therapy. Abdominal pain, especially after high-fat meals. This can happen in both people with type 1 and type 2 diabetes, and some strategies to help avoid smoking, excess alcohol, and keeping a close eye out for people with cystic fibrosis too. If they are having elevations in blood glucose, they might, of course, most people with cystic fibrosis will be on pancreatic enzyme replacement therapy because they really need those enzymes to help utilize all the calories they ingest. I do have to do one quick shout out for pancreatic cancer. So pancreatic cancer is so hard to detect until, it's progressed. And a few things I just want to mention as we're working with people with new diabetes, we just want to do real careful history and physical, hear if they have any genetics for diabetes. If they don't, we're like, what could be causing this sudden onset of elevated blood glucose levels? And seeing if they have any associated signs of pancreatic cancer, abdominal or mid-back pain, loss of appetite, jaundice, weight loss without trying, nausea, change in stool, of fatty stools. Because, we know that pancreatic cancer is deadly. We want to catch it as early as possible. Okay, so you're doing so great. Now we're making it to the liver, and you all know we used to use these older terms like fatty liver disease or non-alcoholic steatohepatitis, non-alcoholic fatty liver disease. But the American Association for the Study of Liver Disease say we need a name update to really reflect the pathophysiology, and the American Diabetes Association went ahead and adjusted their nomenclature also. So instead of saying fatty liver disease, we say steatotic liver disease. Instead of saying NASH, we say MASH, metabolic dysfunction associated steatohepatitis, inflammation of the liver with some maybe fibrosis happening and some damage to the liver. And then we have a metabolic dysfunction associated steatotic liver disease, which is kind of the overall umbrella, or MASLD. MASLD occurs when the fat in the liver reaches 5 to 10% of the liver's weight. So that's how we determine if somebody has steatotic liver disease. And it's very prevalent in people with type 2 diabetes. Adults with type 2, MASLD is prevalent, and more than 70% of those, 50% have MASH, the more intensive steatohepatitis. 12 to 20% already have some degree of fibrosis, and this is kind of scar tissue in the liver. And this is why it's so important, when we do that assessment, to evaluate, could this person be struggling with steatosis? And we'll talk about a strategy you can use to evaluate that. And we know that the risk is increased with people with a BMI of 30 or greater if they have other cardiometabolic risk factors like hypertension, hyperlipidemia, they're over the age of 50, and their ALT and AST is 30 or greater. So when you look at labs, you're going to look at that chem panel, and you're going to see what is their ALT and AST. And I know that for many of these values, or many labs have different values than 30. They might let it go up to the 50s or 60s. But the American Gastroenterology Association says no, if the ALT or AST is 30 or greater, it requires surveillance. So really important, because if it's elevated, it's a sign that liver is struggling and we need to help it out. So this is the different stages. We have fatty liver, or the MASLD, and then we have the MASH, fat and inflammation and scarring, and then it goes on to cirrhosis, and then it can increases the risk for that person also getting liver cancer. So let's take a look at Evie. Evie is 58 years old with type 2 diabetes and a BMI of 33. In addition, Evie has hypertension and hyperlipidemia with elevated liver enzymes. ALT and AST are elevated. To determine if Evie is at risk for liver fibrosis and cirrhosis, which of the following would provide a risk calculation? Will we use a UACR, FIB4, GAD, or ICA, or their weight in kilograms divided by the square of height in meters? So they're 58 years old, have a BMI of 33, hypertension, hyperlipidemia with elevated ALT and AST. Which of the following would provide a risk calculation? Wait a few more seconds. Okay, I'm going to go ahead and close the poll. Well, wait, I'll wait a few more seconds. I see some votes coming in. Okay, I'm closing the poll and sharing your results. So we have 20% of you said UACR, 63 FIB4, 13% said look at their BMI, and 6% said look at their autoantibodies for diabetes. So the best answer, and thanks for participating, is actually FIB4. So I'm so glad we're talking about this, because the American Diabetes Association is making a real call out to say, let's evaluate people with diabetes. They would just say anyone with newly diagnosed diabetes, because we know they're so at risk for having MASH or MASLD, that we want to look at their risk using the FIB4 calculator. So you might ask, where do you find this FIB4 calculator? You just Google FIB4 calculator, it will pop up instantly. And it's so easy to do, y'all. All you need is the person's age, their AST level, their platelet count, and their ALT level. So we just need the chem panel results, and then of course the platelet result too from the blood count. And you just plug that in and it gives you a number. And so we want to do this with individuals that are new to us, that we haven't calculated, and or we suspect they might have steatosis, because we want to catch it early. And you can see here, the American College of Gastroenterology considers upper limit of normal ALT levels here. So that's why less than 30 is really the target. Then if this person's FIB4 came back 2.61, what does that mean? Well, if it comes back less than 1.3, they're lower risk. We can just check in on them next year. But if they're in that greater than 1.3 to 2.67, they're having elevated risk. And then high risk is 2.67 or greater. So is this assessment perfect? No, but it gives us some information of what action to take next. And if this person is in this intermediate risk, we're going to send them for more testing. And one of the things we can send them for is a fibroscan. And when I say, we send this, I don't have prescriptive authority. I can't send people for fibroscans, but I am going to advocate on behalf of the person with diabetes to the provider, saying this person has elevated FIB4 score. Can we please, take some more action to evaluate what's happening? And if people in your clinic or your work setting don't know about FIB4, you could share this with them. It's such great information to share and let your providers know. And I'm charting on all my people now that I see what their FIB4 is and sharing it with the providers and just kind of making it part of our conversation. So that's really a very helpful approach. So here's the liver elastography or fibroscan. It's just a little ultrasound transducer, super easy. There's fibroscan vans that travel to different communities, or you can send a person in to get a fibroscan. It takes about 5 minutes. They just use this transducer to see how elastic is the liver, or is there scar tissue? And that's what we're looking for. If there's a buildup of scar tissue and it's fibrotic, then we know that person's moving into steatosis and steatohepatitis. So what can we do if we have somebody with an elevated FIB4 score? There's a lot of great things we can do. For sure, we have strength training. Strength training is going to help decrease visceral adiposity. Yoga, Tai Chi, walking, and aerobics. Thoughtful eating, seeing a dietitian is going to be critical. More fiber, less processed food, less alcohol, and then treatments. So we know that pioglitazone or Actos can actually decrease liver inflammation. The GLP-1s, in particular semaglutide, has been recognized to decrease liver inflammation and amount of fat in the liver. So we're thinking the GLP-1s, because they help with weight loss, they're going to have a class effect of decreasing the amount of fat in the liver. Statins are certainly going to be a part of what we utilize to help people with extra fat in their liver. That can also have an impact. The other thing we want to do is make sure they're getting regular cancer screenings. We want to decrease inflammation, and we want to monitor them closely. Okay, we're almost there. Now we're on the ileum to the anus. So we've made it through the duodenum and the small intestine. Now we're hanging out in the large intestine, where we see the appendix here. And the appendix is a really important organ that will collect bacteria and things that shouldn't be hanging out in our intestine. But as you know, sometimes it gets clogged up and it causes appendicitis. But it has similar tissue to our tonsils. So it's kind of an interesting little appendage here. And then we have our ascending, transverse, and descending, and then it goes out through the anus, and we have our external and internal anal sphincters that are going to regulate when the stool comes out. So the anus is the last 2 meters of the intestine, and to move from the ileum to the cecum, the food has to pass through the ileocecal valve. The appendix hangs out near this juncture, trapping harmful bacteria. And then we have the bacterial party center of your GI tract. So lots of bacteria hanging out here, helping with the end parts of digestion. We have the ascending, transverse, and descending. And then we have our external sphincter and our anal skeletal muscle under voluntary control, and the internal anal muscle, which is not under voluntary control. So this is interesting. So we have 2 sphincters in our that are one's under voluntary, one is not under voluntary control. So we can help us figure out when it's appropriate to have that movement. So people with diabetes, when they come in to see me, often talk about their stools. And I'm like, wait, is that in my department? I'm a diabetes nurse specialist. Oh, as it turns out, it is. We cover head to toe because diabetes affects so many things. So one thing that people can complain about is diarrhea. And some people will say to me, well, I'm having diarrhea. And then I'll ask, well, how many stools are you having a day? And they might go, well, one, but it's kind of runny. That doesn't qualify for diarrhea. It's 3 or more bowel movements a day. Of course, we'll look at each person, independently and evaluate what's going on with them. But this is really the definition of diarrhea. And how do we improve this? Well, improve glucose levels, eat whole foods, lots of water, regular exercise, quit smoking, limit alcohol, and take medications as necessary, if appropriate. And here's some causes of diarrhea. Man, there's a lot of different things that are co-associated with diabetes. Glucose levels elevated, neuropathies, the autonomic kind can cause diarrhea or lead to constipation, metformin, GLP-1s. Like, we usually think GLP-1s slow intestinal motility, but they can actually, for some people, cause diarrhea. So every medication affects that individual differently. And then we have celiac disease, yeast infections, pancreatic insufficiency, which we talked about. That can be fatty stool, irritable bowel, sugar-free foods, especially those with alcohol sugars, can cause diarrhea. So then we have constipation. So if a person tells you, I'm constipated, we're going to ask them, how many times a week do you go? And if they're having less than 3 bowel movements a week, that is considered constipation. Constipation, just like diarrhea, is more common in diabetes, especially if that person's dehydrated. So hydration is going to be key. Getting enough fiber is going to be key. Of course, seeing a dietitian is going to be key. And then they might need some bulking agents like psyllium, or laxatives, of course, based on their doctor's prescription. And then a bathroom habits review. We want to encourage them to go to the bathroom on the usual time, and do that on a regular basis. And also, the way our toilets are set up tends to close the anal sphincters and make it harder for the stool to leave the body. So you want to have them elevate their feet on a stool. And by elevating their feet, it changes the position of the intestine, and it helps the stool more easily leave. So, of course, as you know, before chairs were invented and toilets were invented, we squatted when we went to the bathroom. So squatting is a more natural position for going to the bathroom. And, it's, if we can simulate that using a stool to lift up our feet, getting to the right angle, that can be really helpful. So how many words for stool? I'm not going to have you all type out how many words for stool, but there's a lot of time spent on bowel movements and a lot of thought and energy goes into it, because when our intestines aren't working right, we just don't feel good. And people get very concerned with diarrhea and constipation. They just feel like they're out of balance. So I thought it was kind of interesting from an a word perspective, entomology perspective, how many different words we have for stool, because you can see it's a lively part of our daily experience. And when something is so important to us, we have a lot of code words for this. I did have my teenagers, when my boys were teenagers, help me contribute to this list. But also when I taught a class, people contributed some of their own words. So it's kind of funny. And then, if you don't have the Bristol Stool chart, I really encourage you to download this. It's such an easy way to, have people point at what their stool looks like and then have a conversation about it. Of course, you can see the healthy stool types are the sausage shaped versions, and these other stool types might indicate something is out of balance. So we can have a conversation about that. So how do we promote our, colon health? Well, nourishing gut bacteria, getting enough sleep, keeping active, drinking fluids, alcohol, quitting smoking, going outside helps our colon. Yeah, when we're in connection with nature and we get exposure to different bacteria, that can really help increase our bacterial diversity. Thoughtful antibiotic use, not overdoing it, and meditation, actually, believe it or not, may enhance our helpful gut bacteria. Getting enough sleep is so important because our gut bacteria need sleep too. So when we get enough sleep, they feel better. And then I always joke around with my clients. I'm like, you know, the new F word, right? And they're like, what's the new F word? And I'm like, fiber. I'm just trying to make, fiber exciting because, your grandparents have been talking about fiber. I mean, it's something we try to get enough of, but in our current culture and our food culture, we're not usually getting enough of it. It really takes an intentional effort. So we're trying to get about 30 grams a day of fiber, and beans are such a magical way of getting fiber, but the song, beans, the magical fruit, the more you eat, the more you. So some people might be averse to beans because of that side effect. So I just say start low and gradually increase your bean intake. And I work with a community who eats a lot of beans, and I'm so excited about that because I know how great fiber is for our gut bacteria and our overall health. Also, intact grains, fruits, veggies, nuts, avocados. And we know that when we eat enough fiber, it decreases mortality. And also fiber intake decreases risk of diabetes. So I tell people, look at labels, and if the label under fiber says 0 to 2 grams of fiber per serving, it's a low fiber food. Look for 3 grams or greater. And I say, fiber kind of lets us know on the label how processed this food is. Very processed food has no fiber and probably very low nutrition. But once you see the food with 3 grams or more of fiber, there's more nutrition and it's better for your body. So go for the higher fiber foods. I love this idea it's called the American Full Food Project, the Full Plate Diet. And what they do is they just take the plate and they say, okay, let's use the plate as a starting point, but let's add in more fiber to increase intake of it into our usual meals. Like if people are making spaghetti, can they put in some zucchini and onions that is just part of the sauce, but you don't have to necessarily chew it. It's just there because if you boil it long enough, right, it just becomes part of the sauce and people don't even know they're eating a zucchini. And this is really helpful for kids or people who might not like vegetables. But I'm working with folks who eat sandwiches. What can you put on that sandwich that would increase the fiber intake? What kind of bread can you choose? So instead of having them change their nutrition and their usual dietary intake, I'll just say, how can we use what you're eating now? How can we augment it with fiber so you can increase your daily intake? So we do some creative work around that to see, can we just increase the fiber with what you're usually eating? And then I just have to say to you all, there's so many studies that show when people eat yogurt on a regular basis, it helps decrease rates of diabetes and it supports a healthy weight. So yogurt, because as you can see, has a lot of active cultures in it, is very beneficial for our bodies. And I go for the lower sugar yogurts, the Icelandic yogurt, and there's also kefir. Kefir is really good. It's fermented milk, and it doesn't, if you're lactose intolerant, you can tolerate it because it doesn't have lactose in it. And there is some sugar involved because they have to feed the bacteria, but you can get lower sugar versions of the kefir. And it means feeling good in Turkish. Keyif does. So how do we get to better gut bacterial health? Well, eat more prebiotics, foods with indigestible fibers that nourish our good bacteria, and then probiotics. So people often ask me, should I take a probiotic pill? And I say, well, you don't really know what's in those probiotics. Some companies, of course, have higher quality standards than others. But really the best is to use prebiotics, which is a fiber that feeds your good gut bacteria. By doing that, you improve your relationship with your gut bacteria and also help them sustain living in your intestine for the long run. And then eating yogurts or kefir or sauerkraut, kimchi, miso soup, kombucha, all of these have bacteria that are healthy for us and can augment your already existing bacteria and support them. Well, in conclusion, I'd like to say thank you so much for joining us. And I wrote this little song that I'm going to perform for you as a summary of the importance of the gut bacteria and your microbiome. And the title of this little song, I'm going to use my microphone, is 100 Trillion Friends to Call Your Own. So I'll wrap up with this and then I'll hang out to answer any questions. From the way back when to the current time, man and bacteria have been intertwined. Start with your head, it's a happening place. There's staphylococcus all over your face. Down to your gums, teeth, and mouth, there's streptococcus inside and out. Now to your stomach to keep the pH. H. pylori is on the case. Inside your intestine, 30 feet, a tube, 3 pounds of bacteria digesting your food. Bacteroides to keep you lean. Firmicutes, a junk food digestion machine. Periodontal, another bug on the scene, breaking down fiber, veggies, and beans. Lactobacillus is a newborn's friend, lining birth canal from tip to end. Down to your feet, in between your toes, that's where a lot of Pseudomonas grows. Short chain fatty acids keep them around, protects gut mucus lining from breaking down. So here's my message: always nourish your gut with fresh fruit, beans, veggies, beans, and nuts. More kefir, miso, sauerkraut, kimchi, less sugar, and processed food to keep away disease. Get dirty, breastfeed, limit antibiotic use, and let newborns come out through the natural chute. From the way back when to the current time, man and bacteria have been intertwined. So be reassured you are never alone. You have 100 trillion friends to call your own. Mic drop. On that note, I'll conclude. Thank you so much for joining us. I so appreciate your interest in this very important topic, and I hope you have a wonderful World Diabetes Day, November 14th, and National Diabetes Month for this entire month of November. We have a lot of resources on our website to help you celebrate Diabetes Month, and thank you so much for showing up today. This is Coach Bev signing off. Thanks, everyone. Okay,